folks. We good? We on? Hello. This has been an incredibly busy month. We did the Denver seminar, and then I had cataract surgery on August 1st. And then most of you know that Dr. George broke his hip on July 1st and had it replaced on July 2nd. And because we used the new fracture protocol before the ambulance even came, he had no bruising and took a total of, I think, 3 Tylenol for hip replacement surgery, which was pretty darn amazing. Anyway, so he's doing great. And then I had my second cataract surgery on the 15th, which, as it was 5 days ago. So I can see clearly now. Isn't that, there's a song like that, right? From If You're My Age. Anyway, so there aren't any case reports this month. There's a great case series from Cleveland Clinic that they have on their website that I was going to show you. And if we have time when we get through this, I might actually do that. It's a PDF of their slide presentations of some of the complex cases they have been treating. But what it made me think of was how it is that we learn FSM, how I teach it. And by teaching you the language, how to think about it, when to use it. And I think all of us can do with a reminder, at least that's what this webinar is about this time, is a reminder of how we use what frequencies. And I made some slides for a webinar for Functional Institute for Functional Medicine, and went through the FSM history. And I thought you might like some of the pictures, so I put them in at the front. You know the history pretty much. Frequency-specific therapies were developed in the early 1900s by MDs and osteopaths in the US, the UK, Germany. Those are the major ones, and used by thousands of physicians till 1934. And as we know, medicine labeled them all as ineffective fakes. Drugs and surgery were going to be the tools of medicine. This was what happened in about 1910 to 1934. During that 20 years, they were trying to standardize medicine. And nutrition, herbs, homeopathy, and frequency therapies, electromagnetic therapies, were all outlawed, and any physician who used them would lose his license to practice. So the devices went into the back rooms. The research was lost. You can find some of it in the rare book room at the Naturopathic College. And the practitioners were persecuted. A number of them ended up in jail or lost their licenses. It was a thing. Harry Van Gelder bought a practice in 1946, went into the back room, found this machine under the sheet, and took the sheet off and found a device that was made in 1922, and that device came with a list of frequencies. The list was resurrected in 1995. George Douglas went down and worked with Harry in 1983, brought the list back and stuck it in a drawer. And when I started practice in 94, he bought a Precision Micro, two-digit blue box, brought a Precision Micro device. And we hauled the list out. He found the list, and in 1994, 95, really, we started using the frequencies with the blue box. We really don't know how they were derived. We're uncertain about the mechanisms of action, but we've got a pretty good model for that now. What we do know is the 1920s equipment was not microcurrent. Frequency-specific microcurrent is not about the device anyway. It's about the effect of the frequencies. So the frequencies were first taught in 97, and those of you that survived that era know that they weren't taught very well. But the benefits, the effects, and the effects of the frequencies are consistent, teachable, and reproducible. Research in animals and humans and clinical results have accumulated over the next 20 years. So this is the intro that I did for a webinar for the Institute for Functional Medicine and their energy module, which was really pretty fun. So we know the frequencies work. They produce predictable, reproducible results, but how do they work? What are they doing? the data gives us an idea about how the frequencies might work, okay? We know that 40 hertz reduces inflammation, right? We've got the animal research with the mice and the ears and the 62% reduction in locks and the 30% reduction in cocks. And it's 4-minute time-dependent response, which is a feature that suggests the model we have, the cell signaling model we have, is correct because it takes about 4 minutes to change what the cell does for a living. All of the inflammatory cytokines went down. But then it makes you think, where does inflammation come from? Is there a way for me to move this off screen, Kevin? There we go, got it. Yep, the immune system, where does it come from? The immune system responds with inflammation to either trauma or infection when tissue products from trauma or bacterial or viral cell fragments land on this cell membrane receptor. The receptor activates kinases inside the cell. The kinases activate transcription factors. Is this appearing in your screen? The red and the black squares? Are those there, or are they just in mine? Okay. So the kinases activate transcription factors. The transcription factors change genetic expression. It changes what the genes do inside the cell. Okay, and cause the cell to secrete inflammatory products. So that's where inflammation comes from. It actually is produced by specific genes in the cells in any particular organ or tissue that are programmed to secrete inflammatory products in response to certain external factors that change the way the cell operates, what it thinks about, what it is told to do by these receptors, okay? So that's the background. So we know the frequencies reduce inflammation, but how is that done? So 40 hertz reduces all inflammatory cytokines. In medicine, inflammatory cytokines are hard to change, and when they change slowly over months. But 40 hertz on A and 10 hertz on B reduced all of the inflammatory cytokines by 10 to 20 times in 90 minutes. But it only worked in patients who had spinal cord inflammation. This patient here, the control patient, she didn't have any reduction in pain. She didn't have any reduction in cytokines because her cytokines weren't elevated to begin with. 40 and 10 didn't work on her. It didn't reduce her inflammation because she didn't have any. It didn't create a change in her spinal cord because there was nothing wrong with her spinal cord. Her pain was all peripheral. Even the substance P slide on her is flatline. This is not the placebo patient, but this is the myofascial pain patient that didn't have anything wrong with her cord. So 40 and 10 didn't do anything to her. 40 and 10 only works in patients whose pain comes from inflammation in the spinal cord. 40 hertz is reduce inflammation, 10 is the spinal cord. How does that work? If you haven't thought about that before, I'm not surprised, because it's makes your brain hurt, but that's what we're going to do for the next 60 minutes. So, buckle up. This will be fun. Well, in an interesting sort of way. All right. So cytokines are created by changes in cell signaling, right? Interleukin 1, interleukin 6, TNF alpha, interferon gamma, CGRP, all of the cytokines that changed in that research are all created by changes in kinase receptor configuration, kinases, transcription factors, genetic expression. That's what changes, increases inflammation. And our hypothesis is that only changes in cell signaling could normalize them so quickly. We simply turn them off by changing the receptors and changing genetic expression. All right. So the basic rule of science is you can't throw out the data because it doesn't match your model, right? You have to change the model so that it can explain the data. In 20 years, we've accumulated a fair amount of data. There was a hand raised, so we'll get to the questions in a bit, okay? So drugs or nutrients act like keys in a lock to change membrane receptors and intracellular function, right? We know how those work. Advil, ibuprofen lands on this receptor, modifies its configuration and changes prostaglandin secretion or pro-inflammatory cytokines or prostaglandins, and it's prostaglandin inhibitor. Okay, that's how ibuprofen works, this way, to change what the cell does for a living. Now, the frequencies act like your key fob, your key remote, opening the lock with an electromagnetic signal. They appear to change. I don't have any research, genetic research to prove this, but it's the only thing that makes any sense. And at least it is a testable model. If anybody knows anybody who has a genetics lab that would be interested in testing this out, I'd love to see it proven. So the frequencies appear to change membrane protein configuration and cell function electromagnetically, not with a key and a lock, but like your key fob, opening your car door. I couldn't remember okay. So our model, the model for how it works, our model says that frequencies change cell function by changing genetic expression. So here's the thing. If abnormal cell signaling is the cause of disease, pain, and illness, and if frequencies change cell signaling in many different tissues, what can the frequencies treat? And how do you think about the frequencies in order to apply them to the situation? That's what this webinar is about, is how to think about it, okay? Genes are turned on by, let's say, turned on by injury, determine the rate of healing, right? So the frequencies change those genes and speed up healing. So we've got this post-facelift treatment. Marissa Brennan, this is her patient. So day 1, 2, 5, it's 80-minute treatment immediately post-op, daily for 7 days. And this is what this patient looks like at 11 days. That's not possible. Anybody that has ever seen a facelift patient 2 months after a facelift, she might look like this, but she's not going to look like that in 11 days. So how is it that we're doing this? It's really fun to be able to do it. It's predictable, reproducible. Anybody that's listening right now that's taken the course seminar or read the book can do this. But what are we doing? How does that work? Terrell Owens. Open spiral fracture, torn interosseous ligament, torn deltoid ligaments, FSM for 4 weeks. It was healed and stable at 4 weeks, and then at 5.5 weeks, we took apart the scar tissue, and he played in the Super Bowl 6 weeks after a career-ending injury and surgery. How did that happen? How did we do that? It's nice that we can do it, and it's nice that anybody that's listening can do it. It's nice that it's reproducible, but how did we do it? We aren't using the frequencies to change genetic expression, but the only thing that new injury treatments have in common is this 4-hour window, right? You need to treat new injuries within 4 to 8 hours, 4 to 6 hours after the time of the injury in order to get the optimal, magical new injury response, right? We call it the 4-hour window. Thanks to Diana Cross, we know that the only thing that happens in the first 4 to 6 hours that is unique is these early response genes are turned on in a new injury. They come on immediately, and they are off at 6 hours, 4 to 6 hours. So we have to treat the patient in the first 4 to 6 hours in order to modify what these genes are doing. That's an observation, right? That's what science is about. It starts with observation. So we have this observation. You have to treat them in 4 to 6 hours. What is different between hour 1 and hour 10? The only thing that's different between hour 1 and hour 10 is these genes. My model, our model, says that frequencies change cell function by changing genetic expression. But the new injury treatment focuses on 18 and 62 to stop the bleeding and reduce inflammation, 40 hertz, and repair tissue damage, 124, 294 through 21 and 9. These frequencies don't change the genes, they change the cellular process that turn these genes on. Look at the graph. Time 0, when the genes get turned on, what turns them on? Trauma, injury, right? What is unique about trauma and injury? In general, there's bleeding. You damage tissue, you break blood vessels, and there's bleeding. The tissue is torn and broken, and that stimulates inflammation, and that turns on this whole cascade. We're not treating to change the genes, but we are treating with the frequencies that turn off the cellular processes that turn the genes on. You have to treat the cause. What causes these new injury genes to go on? Bleeding, inflammation, tissue damage. We use those frequencies to treat the cause and change genetic expression. So the cell responds by changing genetic expression. Once the stimulus for the dysfunction is gone, the drivers that create cell dysfunction go away, and the cell can go back to normal function as long as it has the resources that it needs. That takes us back to the whole stable state strategy. So the drivers that create cell dysfunction, have you ever wondered why the frequencies for toxicity reduce pain? Have you ever wondered that? I wondered that. Have you ever wondered why the frequencies to remove mold or pus and pus encapsulated, why does that change pain? Are we killing mold? No, I don't think so. Are we killing bacteria? I don't think so. The frequencies are too low. They're not complex enough. What do the frequencies do? If the frequencies are changing cell signaling, and if toxicity or mold or pus and pus encapsulated or strep or staph or pathologic virus, if those frequencies are modifying the receptors on cells, and those receptors are changing transcription factors and kinases inside the cell to create inflammation or reduce secretions or do whatever they're doing, and we change the drivers that create cell dysfunction, once we change the effect of mold or the effect of infection on this receptor, the cell can go back to normal function as long as it has the resources it needs to do that. So there has to be a stable state to support it. This kind of all hangs together when you look at it as a big picture. We'll do some examples in a little bit. So torn and broken in the tendon, right? Did you ever think about why torn and broken in the tendon works for tendonitis? Because it's not inflammatory. Tendonitis is not actually inflammatory. It's a tendinopathy. It happens when the tendon is injured and can't be repaired within about 24 hours to 48 hours. The cell begins to express the genes to secrete inflammation. 40 and 191, reduce inflammation in the tendon, doesn't work. Never did. I used it for a year. It was my tendon. Didn't work. Why? Because 40 was not the problem. I could reduce the inflammation, but it only lasted 20, 30 minutes. The injured tendon is inflamed and swollen, but torn and broken in the tendon fixes why the tendon cell is secreting inflammatory products. It fixes why the tendon cell has turned on the genes that produce inflammatory products. Why it's time dependent? I think it just takes that long to fix the tendon. It takes about an hour to 2 hours. Those of you that have treated tendons, ligaments, and connective tissue know that it's time dependent. But when you think about why it works, it treats why. It treats the driver that's driving the cell to be dysfunctional. Tenocytes are not supposed to express the genes for inflammatory products unless they're injured. When you remove why the tenocyte is secreting the inflammatory products, why the tenocyte is expressing the genes to create inflammation. If you fix the driver, you change what the cell does. It's kind of an interesting way to look at it, really. All right, so we're going to look at examples of this as we see it in the brain, mostly with the sensory and motor cortex 92 and the midbrain 89. These are all from the core seminar. Okay, so frequencies for the brain. And we're just going to look at really 92 and 89 in various case reports because it's just the last couple of years has been fascinating. So, thalamic pain syndrome from strokes, right? We get rid of thalamic pain syndrome, central pain, 40 and 89. You run that neck to feet. We know that 40 hertz reduces inflammation. I don't have any information that tells me that thalamic pain syndrome is caused by inflammation in the thalamus, although it could be, because it's in response to a stroke, right? So once you have a stroke, the cells are ischemic, they die, they're dysfunctional, there's inflammation. So reducing inflammation in the thalamus would reasonably reduce pain, but it also appears to reduce the activity of the target tissue. So central sensitization, when you treat somebody that has 40 and 10 pain, fibromyalgia from spine trauma, you're reducing inflammation in the spinal cord. We have data that says that. But once their pain gets to a 0, they look confused, right? They've got a funny look on their face because the thalamus is still sensitizing or amplifying pain. There's no brain injury. They haven't had a stroke, but the thalamus is hyperactive. So 40 hertz in that case appears to reduce the activity of the target tissue, in this case, the thalamus. But it also works in phantom limb pain. What's up with that? 40 and 89 is how you get rid of phantom limb pain, right? You treat neck to feet. It doesn't matter which limb is missing. You can treat neck to feet if it's the arm or any part of the leg that's been amputated. 40 and 89 will take down phantom limb pain. It takes about 30 to 60 minutes. But does the patient have a brain injury? No. So is the thalamus inflamed? I'm not sure. I don't think so. So we could say that 40 and 89 reduces the activity of the thalamus in response to missing input from the missing limb, right? That's one way to do it. And then you treat local pain at the stump by reducing inflammation in the nerve. That makes sense. And you treat bruising and inflammation and scarring in the soft tissue, the fascia and the muscle belly and the periosteum and the amputated limb. So 40 reduces inflammation for sure, but it also reduces the activity of, I should have put in the slides from Roger Billiker's heart rate variability study. 40 and 562 quieting the activity of the sympathetics, reduce sympathetic response. And 40 and 709 reduce the activity of the the parasympathetics, and he could manipulate that at will, up or down, just by running 40 or 81. Interesting, isn't it? And then 81 increases secretions. This was, we call it constructive interference. It supports the function of the secretions in the tissue for which it's listed. So this is the ovary study, right? So salivary estrogen at 2:30 was 1.7. At 5 o'clock, it was like 1.4. Treated pituitary, increased secretions in the pituitary, didn't change salivary estrogen. And between 5:30 and 6, we ran increased secretions in the ovary, and that increased salivary estrogen from 1.4 to 37.1. So that is clearly not a placebo effect. Something is real that's happening when you run 81. So somehow 81 hertz changes the secretory activity, affects cell signaling in such a way as to turn on the genes. So it changes that receptor to turn on the genes that cause an increase in secretions that are specific to the organ that's targeted. I want to say that one again, because I don't have a picture of the genes here, but 81 hertz increases secretions, I think, by changing the receptors on the cell that increase, by changing the receptors on the cell that change the genes or turn on the genes that are specific for the secretions from that tissue. It was only 81 hertz on A and 7 hertz the ovary on B that increased salivary estrogen. All right, so let's look at where we use this. This is a fibromyalgia patient. He had rigidity in the peripheral muscles from a spinal cord injury that happened when he was 5 years old. And his muscle tone was incredibly tight everywhere from the neck down. His legs were like bricks. Now, clearly he works out, he exercises a lot, but 40 hertz on channel A and 10 hertz on channel B took down his body pain, but made the spasticity worse. 81 hertz on channel A increased secretions in the spinal cord, relaxed the tone in his muscles, starting from the bottom up. So the legs go first, lower leg goes first, then the quadriceps, then the trunk muscles, then the arms, and then the hamstrings go last. So this is a really consistent pattern. We've been doing this for about almost 10 years now. What's it doing though? Think about it. What's it doing? The only way this works is if somehow 81 hertz changes a receptor in the spinal cord. And that receptor somehow increases or changes the transcription factors in the genes and causes an increase in the secretion of dopamine down the spinal cord to increase descending inhibition. I think it's dopamine, could be something else. I'd love to have some data on it. But it increases secretions in the spinal cord that facilitate descending inhibition of spasticity. The spasticity in the periphery, this increase in tone that happens in patients with myelopathies, spinal cord or brain injuries, the spasticity goes away. It is there because of loss of descending inhibition. There's a constant dial tone that comes down from your brain that says, don't spasm. When that dial tone gets interrupted by something, you have spasticity. It works in cerebral palsy, it works in myelopathies, and it worked in this patient. So 81 and 10 reduces spasticity, specifically that spasticity that is caused by loss of descending inhibition from the brain down the cord to the body. Okay, you still with me? I told you, this makes your brain hurt, at least makes mine hurt. All right, now 40 and 92. So the sensory and motor cortex, I put a picture of the brain here, but we just did that, right? Sensory and motor cortex strip on the cortex. So 90 is the cortex, 92 is the sensory and motor strip in the cortex specifically. If you ever have a patient that is super ticklish, like you go to work on their abdomen or their armpits, and they just bust up giggling and they can't sit still and they're super ticklish, run 40 and 92. Just switch the frequencies to 40 and 92, and inside of 30 seconds to a minute, ticklishness is gone and you can do whatever you want. I've done it enough times that I can say that with some certainty. However, when you have children who have difficulty with sensory integration, right? They're super sensitive to all sensory input, taste, sound, touch. It does seem to work in autistic children, but this is that subgroup. We call them sensory integration patients. 40 and 92 reduces that. And then if you treat 92 for concussion and reduce inflammation, see what happens. Try it on yourself sometime. Run 40 and 92, run 81 and 92 and see what you notice. What happens to the colors in the room? What happens to your sensitivity to sound? What happens to how much sound bothers you? Okay? When patients have inflammation body-wide from a viral infection or GI problems or whatever, when patients have inflammation, you notice that you are light sensitive and sound sensitive. When you have a migraine, light and sound sensitive, where does it come from? I'm going to suggest that it's this, 40 and 92, because you can change it with the frequency. 81 on channel A and 92 on channel B, the sensory and motor cortex. This young lady had a stroke. If you were here for the May, I think it was, webinar, this is a young lady we treated in Taiwan. She was 38 when she was 35. She had a stroke because she had sleep apnea. And her hand was clenched, spastic, flexed. Her shoulder was adducted, flexed, spastic, and immobile. We did increased secretions in the sensory and motor cortex. And look what happened. Excuse me. The spasticity in the arm and the hand relaxed. Pretty soon she could mobilize her own hand. We ran increased secretions, and Kathleen Casbin, the physical therapist, could mobilize her shoulder, and it relaxed. And then I figured, well, we've gotten everything we can out of 81 and 92. So I switched to 49 and 92, and then they did this. And treating the sensory and motor cortex to remove trauma, increase secretions, and restore vitality, this was permanent. She hadn't moved her shoulder in 3 years because these muscles here were spastic. The second treatment, this is what was lasting from the first treatment, and the second treatment did this. That's what happens when you increase secretions in the sensory motor cortex. But what are we doing? Why does it work? What is the spasticity caused by? Spasticity is caused by the damage to the sensory and motor cortex that from the stroke that stop the secretions from the sensory and motor cortex particularly. It stops the secretions from the motor cortex that tells this area not to spasm. Okay, so when you increase the secretions, you get rid of the spasticity. We have much better luck getting rid of spasticity spastic paralysis than we do getting rid of flaccid paralysis. It's a different frequency or something, because flaccid paralysis, I haven't had a lot of luck with in the spinal cord or the brain. But spastic paralysis, increasing secretions from the sensory and motor cortex appears to connect it to the periphery. Now, she has to have a stable state, right, that includes enough protein and amino acids to make dopamine, and protein and amino acids to make acetylcholine, right? Dopamine in particular. 81 and 92. When you treat an RSD or CRPS patient, so if you've seen the video of me treating Adam for CRPS in 2000, whatever that was, 15, 14, the way you get motion back in RSD, CRPS patients and other denervation patients is to reconnect them by increasing secretions in the sensory and motor cortex. What are we doing? Somehow we have to be affecting the receptors on the cell that change the transcription factors, that change the genetic expression, and cause this cell to start secreting the peptides associated with motor function. You with me still? Okay, hang in there. So this is from Regina Thompson. She is a physical therapist at Cleveland Clinic, and we've had an ongoing discussion. If I finish early enough, I'm not going to finish early enough. I'll show you the presentation that is on the Cleveland Clinic website that they've done with spasticity and treating different neurologic conditions in their pediatric patients. So this is a pediatric rehab hospital. And these folks see some very difficult patients. So we're talking about reducing spasticity by increasing secretions in the spinal cord. 81 and 10 is this is from an email I got from her today. 81 and 10 is especially good, but nothing beats 40, reducing inflammation, pain reaction, spasticity, then increasing secretions and vitality in the spinal cord. But look at this. It's 5 minutes each. It doesn't take long. When what you're doing is changing cell signaling, you change the signal. It's like opening your car door with your key fob. It takes 5 minutes to do this. Reduces spasticity every time. We use a longer version of that for tougher cases. So the more difficult and refractory the damage to the cell and the dysfunction in the receptor, the more difficult it is, the longer it takes to what? To change this, to change the genes, to wake up the genes. I would love to be inside a cell. I would love to know what we're doing. She also uses 81 increased secretions. 988 is from the basal ganglia, is from the advanced, is for the basal ganglia. So she also uses increasing secretions in the basal ganglia and the cerebellum to improve coordination and motor planning. So this has been very successful in a child with lissencephaly, is a dysfunction in the brain, basically underdeveloped basal ganglia. And she's going to find it because the protocol has been so effective. However, this is from Ben Catholi. Dystonia patients are hypertonic, right? They have too much drive from the basal ganglia, so it makes them spastic. There's too much. That's what dystonia is. It's too much. So increasing secretions in the basal ganglia makes the tone worse, but quieting the basal ganglia and treating for trauma in the basal ganglia is pretty cool. So 5 years ago, these guys took the core seminar and they learned the language, and then they have a place to use it. I don't know that we think about the fact that we're probably changing cell signaling. Most of us in medicine are pragmatic. Is it going to work? What does it do? But it makes you think, right? Do you want to quiet the activity of or increase secretions? You'll know in about 3 to 5 minutes whether or not it's going to work, but it lets you think about what it is that is causing the patient's symptoms. Increasing secretions in the basal ganglia made this Parkinson's patient go from spastic and tremorly to not spastic. It basically effectively reduced his Parkinson's symptoms by about 80%. It's not going to hold because there's no stable state. There's not enough cells in the basal ganglia there to repair, and he's way over medicated. But just the fact that we could change the Parkinson's symptoms by treating the basal ganglia for toxicity, right, to help change the signaling, that has been damaged or affected by toxicity, fibrosis, inflammation, chronic inflammation, scarring, whatever you think is impeding the function of the cell that is driving the change or the dysfunction in this receptor. So in Parkinson's, we know it's associated with toxicity, sometimes viruses, but toxicity. So you want to treat that to remove the effect of the toxins, but you also want to drive secretions in the basal ganglia. So our model says that frequencies change cell function by changing genetic expression. So if abnormal cell signaling is the cause of disease, pain, and illness, and if the frequencies change cell signaling in many different tissues, what can the frequencies treat? Kind of makes you think that we can treat just about everything, which I think is true. But then how do you think about them? It's a good thought experiment. You know that patients that have spasticity, if you run 40 and 10, it'll make the spasticity worse. If they have body pain and you run 81 and 10, and what you're increasing the secretions of is substance P, you're going to make the pain worse. But 40 and 10 will take the pain down, and 81 and 10 will take the spasticity down. And I have had patients where I had to run both at the same time. That's the thing that knocks me out. You can do both at the same time. I've run 40 and 10 on a patient, and at the same time, run 81 and 10 on the same patient, and the pain went down and the spasticity went down at the same time. It's kind of mind-boggling, right? So you change the pattern by changing cell signaling, treat the cause by changing cell signaling and by supporting the stable state. So if you are trying to fix somebody with atrial fibrillation, you have to increase secretions in the vagus nerve, right? Is there any point in doing that if the patient doesn't have enough choline? Acetylcholine is what the vagus nerve uses as a neurotransmitter, right? If the patient doesn't have enough choline, will you be able to sustain the treatment of atrial fib? No. So supporting the stable state, yes, you can make a change. Toxicity in Parkinson's, support the stable state. He's not around the toxins anymore, but you have to help repair the mitochondria with lipoic acid and CoQ10 and all of the sub-stable state stuff that we know to do. It's totally fascinating. Well, we're just about at the end. This is so much fun. I love these things. Today was really fun. I had a great time. Hope you did too. Hope it didn't make your brain hurt. We've got 3 seminars left this year in the US. We're going to be in London, September 13, 14, 15, and 16. And at the Osteopathic College, it's basically down by London Bridge. It's just a lovely area of town. Then we'll be in Jacksonville on October 25th to 28th, Minneapolis, November, and San Francisco in December. And I encourage you to come and take another core seminar. It's different every time I teach it. And these concepts of what causes, how we're using frequencies, and what they're actually doing. I love being pragmatic and I just like fixing stuff. But every now and then the mind wanders to what it exactly is that we're doing. Just a reminder, there's a new FAQ brochure. It's updated information. It's easier to read. It's a lot prettier. And I cleaned up some of the text, so that's lovely. We print them off. Shelton Turnbull does the printing for us, and we sell them just above our cost. I think for a while there, we were losing money on them. So you can buy them from us, or we will actually send you the PDF, and you can have them printed yourself. I'm not proud. These are really useful for patients so that they know what you're doing and what services you have to offer with FSM. I'm going to encourage you also to share the resonance effect with your patients and colleagues. It is proven to be really readable, and patients like it. So it will give your patients a better idea about what you do and why you do it and what's possible and how the effective frequencies and resonance can be used to help them and what you're doing with it. So that's pretty exciting. I know what I forgot to put in here was the practitioner list subscription. Website practitioner list subscription. Kevin will be sending out a notice probably about once a week, so that it's only $89 a year. Patients are looking for you to come to you to get treated, and we had to start charging for it so that there was a way of renewing your subscription so that we could keep the list accurate and up to date. $89 a year. If you get just one new patient off of it, it'll be worthwhile. And it's good, inexpensive advertising. So I recommend that you sign up for the website practitioner list if you haven't already done that. And then 2019, the Advanced Symposium is coming up. The core seminar is March 14, 15, 16, 17 at the Crown Plaza, San Marcos, and it's in Chandler, actually, just outside of Phoenix. The 18th and 19th, Kim Pittis is doing the sports core right after the core seminar. The 20th is the instructor training. So the FSM practicum instructors, so you can help us out at core seminars, and ultimately so that you can do the practicum instruction for students who have taken the course by textbook or on DVD. Our instructors are a really crucial part of the spread and sustainability of FSM. When we had the core seminar in Denver with 42 students, we had 4 instructors. Sue Spicer, oh, come on. I can see faces, so I can't remember names. It's too, never mind. Mary Miller, and the nurse practitioner. And yeah, Kevin's fried too. Sorry, I can see your face. Anyway, it'll come to me as soon as I stop talking. Anyway, the 21st and 22nd is the advanced course. It's new frequencies and treatment strategies. We've got your favorite faculty will be back, I hope. Expert workshops, the 90-minute workshops, and then I do the basic advanced stuff in the mornings. And then 23rd and 24th is the FSM Symposium, and this year the speaker list is just stellar. Jim Oshman will be back. Gerald Pollack, who wrote Cells, Gels, and the Engines of Life. He also wrote The Fourth Phase of Water. Gerald Pollack is going to be there. He'll do a 90-minute workshop. Juliana Mortensen is a medical physician, an MD, PhD, who has actually patented frequencies to kill viruses. And I want to hear that story. She does a great lecture on the physics of how frequencies could be doing this, but I'm going to see if she'll grace us with some information about what her virus frequencies did and how she used them. Jim Turner is the attorney that helped us make it through our FDA audit. And Diana Cross will be here from Australia. I don't know what she'll talk about yet, but every time she comes, she makes the sun come up. She opens up a door that then feeds what we do for the next 3 to 5 years. And then there are practitioner case reports that are pretty exciting. Remember that there's a $1,000 prize for any practitioner who publishes a case report, and we have 2 of those to give out this year. Regina Thompson has a paper published, and there's somebody else with a paper in the pipeline. So if that is published by March, there will be $2,000 checks to give out. Be sure and consider publishing a case report in any sort of peer-reviewed journal, or collect a case report. That's how we are going to make ourselves sustainable. It's how we earn credibility for your practice and for FSM. So here's what you're doing. We're changing medicine. We're doing it one patient at a time, one stroke patient, one fibromyalgia patient, one dystonia patient, one spasticity patient. And each one of those patients that are treated successfully changes their lives. And every practitioner, everybody listening, and everybody that contributed to the results in this webinar, one practitioner, you, just you, one practitioner can change lives in ways that will constantly surprise you. It blows me away all the time. And changing even one patient's life can change the world. So thank you for joining us. Enjoy what you're doing. And thank you for making the world a better place. And we'll see you next month.